This presentation is regarding how to present an X-ray with a bony lesion. This is a 33-year-old male, previously well, community ambulant, having no known comorbids, presented to us through OPD with 6 months history of progressive pain in his right knee that aggravates with walking. There is no associated fever, night sweats or weight loss. There is no instability in his right knee. Examination is unremarkable for any skin breach. Distal neurovascular status is intact. There are no signs of instability in the knee. The patient is mobile with crutches. He walks with antalgic gait. Inspection shows swelling at the superior medial aspect of right proximal leg. On palpation, there is tenderness to deep palpation. There is localized warmth and erythema. This is the radiograph of the same patient. You can see a lesion present in the proximal tibia, but there is a systemic and a good way to present the radiograph. First of all, we should undergo a general overview like the rest of the radiographs. We should comment upon the views, like this is the X-ray of the right knee, AP view and lateral view. Then we can also comment regarding some technical terms like exposure, penetration, any rotation or malalignment or any associated fracture, etc. Then we turn toward the most obvious finding, and these 8 terms should be addressed. These 8 questions should be answered in order to properly present a radiograph of a tumor of the bone or a bony lesion. The first question is, what is the lesion or what type of lesion it is? Second question is, where the lesion is located? Then what is the lesion doing to the bone? Then what the bone is doing to the lesion as a reaction? Is there any cortical breach? Is there any soft tissue involvement? Are there any internal septations or intralesional calcification? And what type of zone of transition is there? Whether it is a narrow zone of transition or there is wider zone of transition. So let's start with our first question. What is the lesion or what type of lesion it is? So it is basically a cavitating lesion or expansile lesion or lytic lesion. Lytic lesion is the proper word. So it is basically a lytic type of lesion. Then where the lesion is located? So it is a juxta-articular lesion in the proximal tibial metaphysis and epiphyseal region. A third question is, what is the lesion doing to the bone? So it is basically a cavitating and expansile lesion. It is expanding the bone. The fourth question is, what the bone is doing as a reaction to the lesion. In some cases like Ewing sarcoma or osteosarcoma, there is periosteal reaction resulting in Codman triangle, sunburst appearance or onion skin appearance. So none of these signs can be appreciated, which rules out any cortical, which rules out any periosteal reaction, or there is no bone reaction in response to the lesion. The first question is there any sign of cortical breach? So on AP view, the lateral medial cortex seems intact. On lateral view, the posterior and anterior cortex, they also seem intact, but superiorly the lesion seems to be bridging the cortex into the joint space. Then there are no signs of soft tissue involvement. The lesion seems to be confined to the bone. Then regarding the septation, they are visible especially on the AP radiograph, but there are no signs of intralesional calcification. The last question is the zone of transition, and by zone of transition we mean whether there is clear demarcation with pinpoint accuracy between the affected and the normal bone. So the demarcation can be made clearly between the diseased and the normal bone, so there is narrow zone of transition, and all these signs are suggestive of a benign bony lesion. Based upon the radiographic findings, the location of the lesion and the age of the patient, the most probable diagnosis, the top differential is giant cell tumor, and the second top differential is aneurysmal bone cyst.